Yes, if you just let me know when
Okay.
to.
Hello everybody. My name is Jeanette Core. I'm the clinical lead of the Relationship and Sexual Service, and
I'm Al Constantine, psychosexual relationship therapy trainee.
Okay, next slide, please. So we're going to talk to you today a bit about the Relationship and Sexual Service, how it's working at the moment, and how you can refer into it, and then have a case example at the end as a kind of demonstration of how psychosexual therapy works. So just a bit of background for those of you who've been working in the Sheffield area for quite some time. The service has changed quite considerably since 2015. So I know that's going back you know, a number of years, but prior to 2015, the Gender and Identity Clinic and the Relationship and Sexual Service ran as one service, and it was a large service. At Porterbrook Clinic had, you know, an international reputation. There was a teaching course and there was a research arm. But in 2015, financial restrictions meant that the service was reconfigured, and from about 2017 onwards, it was left with just 2 psychosexual therapists. The service did close for a short time, particularly because there was no staff in place from about 2019, I think, and then with COVID. We're back open. We've been open since March 2022, and we are fully staffed. So there's 4 of us working clinically into the service, and we've got a couple of trainees and an administrator. But the important thing, I suppose, that I'm kind of like wanting to get across is that we're a purely psychosexual therapy service. So we don't have any medics working here. So we can't do any physical examinations or request any bloods or take any bloods. So this is why we kind of like often will write to yourselves as GPs and maybe request bloods or request a referral elsewhere for a physical exam if we think that's important. Okay, next slide, please. Yeah, how we work at the moment. So we've got an updated website which is worth having a look at. On there, it's got our referral and exclusion criteria. So I joined the service in March last year, and I benchmarked the service against other psychosexual therapy services in the country. So it is consistent, our referral and exclusion criteria with the picture nationally within the NHS. There's a referral form on the website that you can download to refer to us. We ask that all referrals come from GPs. There is a query helpline, so you can phone our administrator and book into that. So if you've got queries about, is this person appropriate for our service, or if you're wanting some information about how to support that person, more than happy to speak to you. I spoke to a GP yesterday and I think it was really useful for both of us. Just to let you know about the waiting list. So our waiting list has fallen quite dramatically. So it was, when I came into post, it was kind of like over 2 years. We're now booking patients in who've been referred in May of this year. So we're looking at about a 5-month wait for them. We do expedite some referrals. Those are specifically for people with life-limiting diagnoses. And it's usually the diagnosis, for example, cancer is the thing that has caused the sexual dysfunction. So we're happy to receive referrals and place them at the top of their waiting list. And similarly, if somebody is experiencing fertility and issues and has been for some time due to the sexual dysfunction, we'll expedite those referrals. Just to say that on the website, there's a bunch of waiting well resources, all of which are appropriate to be read by clients. So do point them in that direction if you discuss referring them to our service. A quick explanation about the service model. So once you've referred into us, we'll triage the referral within 1 to 2 weeks, and then we'll send out an opt-in form for the patient to complete. That asks some more questions about the nature of the difficulty that they're experiencing, and hopefully by the nature of those types of questions clarifies for them that it is a psychotherapy service that they'll be attending. We then offer 2 assessment sessions, both of which are an hour and a half each, so they're fairly in-depth, but it is a bit of an iterative process, really, assessment and treatment, because treatment is really starting during that assessment. If we decide that they're appropriate for the service, we'll write to you to let you know. and then we'll see them for 10 follow-up sessions, and write to you at discharge as well to update you. We do manage client expectations quite carefully when they start coming to the service, because it's only a 12-session model. So we often talk to people about that they might not necessarily get to the point of kind of like cure by the end of their therapy, but they should be in a much better place. But if they are wanting further work, then they can come back to us. It's not kind of like, oh, once you've been seen, that's it forever. But we do request that they only get re-referred after a 6-month break, and that's really to give them opportunity to consolidate some of the learning that hopefully they've achieved with us. Okay, next slide, please. So I'm not going to go into this in detail because it is on the website, but just as a brief overview, this is the service eligibility. So mainly what we're accepting clients for is when they've got a sexual dysfunction as identified by the DSM-5. There are some more kind of like more generic issues that we'll work with. So for example, relationship difficulties, where that's mostly because of the sexual problem, but we do require the relationship to be in a good enough position to make use of the psychosexual work. So we don't do purely relationship counselling. And we do work with problems of libido, whether excessive or reduced, and with some specific sexual phobias or fears. Okay, next slide, please. Again, this is on the website, but just to highlight, we do have some exclusion criteria. So we don't work with sexual compulsivity or paraphilia, or any sexual behaviours that might be at risk of bringing the service user into conflict with the law. If the sexual difficulty is primarily to do with an organic issue, then we won't work with those issues, and we won't work when somebody's in crisis in their mental health, because they have to be in quite a stable place to be able to make use of the kind of work that we do with them. We also we don't offer support for clients who are wanting to explore their sexual orientation or gender identification. But what we do is we work with people of different sexual orientations or gender identifications who are experiencing sexual dysfunction. And we don't get many referrals for that client group. So I mean, it's something that we're working on to see how we can extend reach into that community. Okay, next slide, please. Just to talk a little bit about pathways with other services. So we have a pathway with andrology and urology at STH, whereby all male-bodied people with erectile dysfunction get referred straight up there. So if we receive a referral regarding erectile dysfunction, that will come straight back and with a request that you refer them to andrology and urology. Also, if it looks like that person is experiencing their sexual dysfunction is mostly organic in origin, we'll ask them to go to andrology and urology first. And that is because, so andrology and urology have a couple of psychosexual therapists working within it. And if men get seen there, then that means that they can have a medical assessment alongside a psychosexual therapy assessment. So they can have prescriptions, or they can have various devices fitted, none of which we can do here. Sometimes they are seen there and the problems are persisting, and it becomes more apparent that it's psychogenic, and then we're more than happy to accept a referral. Similarly with gynecology, they have a vulvodynia clinic. So we have a pathway agreed with them whereby women with provoked vulvodynia get referred first and foremost to gynecology, where they can have a medical exam, and there is a clinical psychologist that works into the vulvodynia clinic, and she can offer up to 5 sessions. And there's an agreement again that if more is needed, then after that, then they can come here. Just some information about a couple of services that we work quite closely alongside. So pelvic floor physiotherapy, we frequently refer women there for who've got vaginismus and sometimes dyspareunia, but it might be something that you want to consider yourselves as at the same time as making a referral to us. If the presenting issue is vaginismus, is to refer to pelvic floor physiotherapy, because we try to take an MDT approach and work alongside physiotherapy with that particular issue. And the other thing is services to mention birth and mind at the Jessops. So when we are seeing women who are experiencing sexual dysfunction and there's been a birth trauma, then we assess quite carefully and are often in consultation with birth in mind to try and figure out whether the trauma needs addressing around the birth before we work with the sexual dysfunction or vice versa. Next slide, please. Again, I'm not going to go through this in detail. The information is on the website, but we do, it is really helpful for us to know that certain bloods have been undertaken for different presentations before we see that person. It just means that we can be sure that we're dealing with a psychological issue and not that there's some organic contributory factors. And similarly, some presentations, it's useful to know that that person has had a physical exam. Okay, next slide, please. In terms of things that we might contact you about in terms of like prescriptions or things that might be useful for you to consider sort of like as the point of referring to us. So you can prescribe Amiel comfort dilators to women with vaginismus. We quite often will write to you about that. Lidocaine, you'll be aware, we quite often recommend that women can buy that over the counter, but a prescription can be useful again for women with dyspareunia. Emla cream for men with premature ejaculation or using condom delay. The lubricants we recommend are by a company called Yes, and they are purely natural, so they've got the least likelihood of irritating the skin, so that's why we recommend them. And where condoms aren't being used for safe sex or for contraception, people can mix the water-based and the oil-based lubricant, which is very effective. It causes something that we call double glide. So that's something that's useful to point clients towards. Sildenafil is useful to consider for women who are struggling with arousal or orgasm at a lower dose, 50 milligrams. Tadalafil for men who really don't like the planning that sildenafil involves. Tapoxetine is useful for men with premature ejaculation, as is Seroxat. Okay, next slide, please. Just helpful things that you might be able to talk to patients about at the point of referral is if they've got vaginismus or dyspareunia, to start to encourage them to do some pelvic floor exercises. There's a YouTube, I don't know what do you call it, site video called the Flower Empowered, which talks women through pelvic floor exercises. There's an app which isn't for free, but that will guide them through those exercises. And there's some alternatives that are free. A couple of books there. The When Sex Hurts one is really quite dense. So you might want to have a look at it before necessarily recommending it. My Broken Vagina is by a woman who suffered with sexual dysfunction, and it's a very easy read. It's kind of like listening to a peer. So I think a lot of women that I've spoken to feel a lot less isolated once they've read that book. For premature ejaculation, the P app is free, and it's got exercises on which are the same that we would be taking men through, so it can be really useful. Female Desire, there's a couple of really good books by Emily Nagoski and Karen Gurney. Emily Nagoski has got her own website, which has got some useful web sheets and information on. And Karen Gurney has got a TED talk on YouTube called The Truth About Desire, which is about 10 or 15 minutes. So that's really useful. We often point women to and men to looking at that. And then a more kind of like generic overview of rethinking sex and relationships. Very readable book called Rewriting the Rules by Meg John Barker. Okay, next slide. Okay, so I'm going to hand over to Elle, who's going to talk through this case.
Hi, everyone. Yeah, I just wanted to talk you through this case example just to give you an idea of actually what happens in sessions as we might go through things with the client. So this client is a white, cisgender, straight woman in her late 20s. She's been referred with pain during intercourse and struggling with penetrative sex. Often we don't get that much more information other than those things. That might be a starting point for us. Next slide, please. Okay, so the assessment, obviously, as Jeanette said, the assessment sort of is quite an extensive process, and we have these 2 assessment sessions that last 90 minutes each that allows us to gather lots of really helpful information. And with this, client, we find out quite a lot about her. So we find out that the vaginismus she's experiencing, the difficulties with penetration, is lifelong. She doesn't know what penetrative sex would be like. She's never successfully had penetration. We find out that she's got an anxious person as an adult, but also that she's been anxious throughout her life. So family environment where there were quite high expectations, lots of pressure to succeed. Also in the mix, we find that she's got a parent who misuses alcohol. And thinking about the connections between that and being an anxious person as an adult as well, and possibly feeling quite responsible as a child. We find out that the partner that she's with right now is very supportive, so there's no pressure from them to, no expectation to that penetrative sex should be happening, but nevertheless she's feeling like a failure, and she's feeling ashamed and embarrassed and generally quite low about the whole situation. And another factor that's into play is that she, as is the case with a lot of people, not much sex education other than around contraception and safer sex. Okay, next slide, please. So we've done these 2 assessment sessions, gathered all this information, and one of the things about the assessment is it really gives the client a chance to tell their story, and it's often the first time they've really had the space to do that. So it's quite a sort of, I think for a lot of clients it can be very, very challenging because they're being asked loads and loads of really intimate questions, but also often it's the first opportunity they've ever had to have someone feel interested and to feel like they've got the space and the time to really talk about this stuff. So that's part of that process, and that carries on through all the sessions, I would say. So in terms of treatment, it's kind of we've divided it up into these different sections because although they all interact with each other, it gives an idea of how this client was worked with. So first of all, we're kind of doing quite a lot of psychoeducation. So information about pain and the pain cycle and how that impacts on the body, information around anxiety, information about vaginismus, what it is, what's actually happening to the body, because often clients will come in and say, we tried to have penetrative sex, but it's like there's a block there. My partner's penis just cannot get up there because there's something in the way, and so we need to explain what that's about. So that might be part of the process. We might talk as well about models of arousal, how arousal happens, the different ways we can understand that, how pain can interrupt that, how anxiety can be a break to a cycle of arousal. And there might also be some education around how to communicate about sex, because if there's no guarantee that just because you're trying to have sex with your partner that you're able to talk about it. So with this client, there was quite a lot of discussion around that. In terms of behaviour, obviously part of what we do is we want clients to change what they do and how they do it. It's not just about sitting in a room and talking about things. So part of the process is to say, okay, with this client, she's got vaginismus, so we might suggest using dilators. We might say, go home and try and work on this process. Alongside that, we'll be suggesting breathing exercises, maybe some grounding exercises, pelvic floor relaxation exercises. So a range of stuff that they can go away and really practice. And that's because we actually need to get clients to connect their body and their mind and how everything works together. Challenges are slightly is very much part of the work we do, and it's quite difficult to clearly describe what that's about. But one of the things that we spend quite a lot of time with clients talking about is challenging their ideas around what's normal sexually. So they will often come in, and as this client did, and go, what I want is to be able to have penetrative sex and for it not to hurt, and for me and my partner to have a successful sex life. And that's very much connected to that idea around failure, a narrative of not being good enough. And so one of the things we will do is gently challenge people to explore the idea of what sex means, where their messages around sex have come from, what sex could mean if they start to think about things more creatively. Like, what do they define as being sexually intimate, and what do they define as outside of that? Getting to people to really sort of expand their idea of what their sexual repertoire might be. so that it isn't just about penis and vagina sex, it's about something beyond that. And what that does really, the challenge is, I mean, the way I described it was, it's giving people permission to think about sex differently, and it's also normalizing their experience. It's going, actually, there are lots of people who don't have penetrative sex regularly or ever, and they're fine, and you're fine too. And that can be really powerful for people to hear that message and to have that message repeated over the course of sessions. In terms of feelings, you can do all the behaviour work and you can give people lots of information, but if you haven't acknowledged their feelings and so they feel listened to and empathised with and understood, then you're not going to get anywhere, because they need to feel that they have the space, that it's a safe space for them to go. The last 2 weeks were really crap and nothing worked the way I wanted it to, and I feel really down about it. So they have to have that space to be able to explore that stuff. And the final part of the treatment process really is around encouraging clients to reflect on their experience. So how have things gone for you? How did it feel trying that thing out? What was it like having that conversation with your partner? And by doing that, this client, for example, starting to really think about how she understood sex and starting to realise things about her relationship and how she might want to change that, and how they as a couple can change their relationship together, rather than feeling, I have this problem, I'm not good enough, I'm a failure. So there's a real opportunity there in the course of the sessions to reflect and explore on how people feel about themselves. Okay.
Sorry, I'm not. Can I have the next slide, please, Claudia? So this is, I mean, we'll finish here, and I'm not going to read through them all because I think you've got the presentation sent to you, and we want to have some time for questions, but it's just some comments from our service users over the last 18 months. Generally, a lot of satisfaction with the work that they've been doing. So yeah, so we can answer any questions if there are any questions.